during fire, we just come to you with this praise, God, just for the awesome way you gave us, Lord. And Lord, I pray, God, that we just make decisions, God, that we'll just better Cherokee's, Father. And God, most of all, Lord, that just honor you. And God, we pray for those who are sick, God. We pray that you just bring healing, God, to their bodies. And Father, and God, we just thank you for all things. And most of all, thank you for your Son, Jesus Christ, and the cross. And all these things. Amen.
Thank you. Next is the approval of the minutes of the January 16th meeting.
Roll call. Janelle Fulbright. Here. Dick Lay.
Here.
Bill England.
Here.
Jack Baker.
Here.
Joe Bird. Julia Coates. Here. Jody Fishinghawk. Here. Meredith Fraley. Here. John Garvin. Donna Gloria Jordan.
Present.
Frankie Hargis.
Here.
Jack Hoskin Jr.
Here.
Lee Keener.
Ahame.
Curtis Snell.
Here.
David Thornton. David Walkingstick.
Here.
Kara Cowan Watts. We do have a quorum.
Thank you. We need to approve the minutes of the January 16th
Make a
meeting.
motion to be approved.
All in favor?
Aye.
Minutes are approved. Next, we have reports, the Family Service Unit, Mr. George Valuers.
Good morning. The hospital report was in your packet. Our revenues are up. We're up a little over $300,000 over this time last year. The report in there says that we are still recruiting for 2 OB-GYN docs. We've actually hired one that used to be there. He's been gone about 3 years, Dr. Hilliard. He's coming back. He's due to start in about 3 months. We have finalized we've chosen a design for the MRI addition and the remodel of the emergency room. Those are both going to the architectural firm for final drawings so that they can be put out for bid. We should have the MRI. The goal is to have it by April to go out for bid. The target for the emergency room is by the end of the summer, so that we can get those out for bid. The other thing that I went around and handed out, it's the same report that I had handed out before. The denials by county. Counselor Watts had asked for deferred CHS cases to be added to that, so the 2011 and 2012 deferreds are added to that if you'll just in an adjacent column. But the rest of the report is the same one that I'd handed out before.
Do we have any questions for Mr. Valuers? Yes, Mr. Lake.
Thank you, Madam Chairman. So let me get again the MRI status. You're going to bid out the room for it to be held in April, correct?
We had to go and the architectural and engineering firm brought us they brought us 3 preliminary designs. Where it's going to go is that courtyard, that open courtyard that's in the middle of the hospital, that little donut hole. It's going away. So they brought us 3 preliminary designs, and we picked one of those. We finalized that and decided on one, and now they're going to go do all the detailed architectural stuff for that and come back with all the final details and specs, and that will go out for bid to the construction companies, and we'll take bids from construction companies on that final drawing.
And how long have you all had this MRI now in your house, in-house?
Oh, we don't have it in-house yet.
Where is it?
It's apparently, what I'm told is it's still sitting at the vendor. The vendor has it.
Who's the vendor?
Toshiba.
And how long has it been sitting at the
I think it was actually awarded about a year ago. And that was through area office in Oklahoma City.
I'm sorry?
That was through area office in Oklahoma City.
And your budget for these contract referrals, has that budget gone down through the years or just stayed level? Is that why we can't get more contract referrals through Claremore or what?
Contract, as in contract health or for, yeah, our contract health budget has pretty much remained flat. We got a little bit of a increase 2 years ago. But the biggest increase for the federal system, they added almost $20 or $30 million to the SHIF funds, which are held up in Rockville, and we have to put in for those. And what those are catastrophic cases, anything over $25,000. We're responsible for the first 25, and then we apply for those funds that will pay for the remainder of that. But we're still responsible for the first 25. So if you have a case, a $100,000 medical case, we've approved it for payment. What we do is we pay the entire amount, apply for the SHIF funds, and they reimburse us $75,000 of it.
Do you hold up those referrals until you get their money, or?
No. It has to be paid first. I would have to pay your $100,000 bill and then get reimbursed.
And get it back?
Yes.
And so, how do y'all fix this? More funding, is that the only answer, or what? As far as your contract health turn downs on these referrals?
Probably in a nutshell, yes. We've sat down and studied and looked at different ways to stretch the money we have. Then on the back end, on the business side, things that we have approved and obligated money for that patients don't come back. We actually have patients that get approved for funding that don't ever come back and have their appointment made and don't use that. Well, that money's still tied up. So we come back we try to come back within 90 days and de-obligate that money so it can roll back up and be used again. So we're trying to cover all the bases on the business side to make sure that money gets, if it's not spent, it's reused.
How do you communicate or relate or whatever you need to do at your level to whoever sent to the feds, the federal government, budgetary people, to give you some more budget for that?
What we do, the way that system works is we have really detailed reports, even more complex than that go up through Oklahoma City. Oklahoma City then for the Oklahoma area pulls all of the reports from all the Oklahoma facilities into an aggregate report and then sends that on up to headquarters, and then headquarters does the same thing for the national facilities for all the 12 areas, and then they send an aggregate report on up to Congress.
And here again, I mean, it seems like that y'all should be lobbying this group. Are you doing that? No, you don't do that.
Well, as a federal employee, I can't do that.
You can't go ask your supervisor, tell him you're in dire straits.
Well,
Claremore, Oklahoma, and ask for more money. Okay.
Well, I let the area director know constantly, that we're short of funds, and we show that. We send in reports to them monthly showing, the number of cases that were denied, the dollar amounts that were denied and deferred. So they're aware of that, but yet the funding comes from a higher level, and the distribution of that funding comes from a higher level than him. But yes, I do let them know that.
Okay, good. And we're building a new IHS hospital in Miami, is that correct?
That's a tribal facility.
Tribal facility.
The tribes are doing it.
The tribes are doing it.
Yes, sir.
It's not going to be like Claremore IHS.
No, the tribes it's a compacted facility.
So we're stuck with what we got, is what you're telling me.
Pretty much, yes, sir.
Thank you, sir.
Councilor Hoskin is next.
Thank you, Madam Chairman. And before I had a contract health question, but I appreciate Councilman Lay raising the funding issue. It's fair to say that Congress is not in the dark about the fact that they do not fund Native American health care the way it should be funded. I mean, I think the highest estimate I've seen is about 60 cents on the dollar.
Yeah.
They know this, and yet there's this philosophy in Washington that we need to make sure, and I'm not asking you for a response because you can't give me one, that we need to make sure and keep taxes low for the highest income earners and don't meet our priorities for Native Americans. That's a philosophy that's the order of the day, and until that philosophy changes, I don't think we're going to see a change, but we can keep pushing for it, and I hope that Cherokee Nation pushes in that direction to the extent we influence the policymakers. I did have a question about contract health. Is it possible, or I guess I should say, is there anything that would stop Claremore from notifying Cherokee Nation every time a Cherokee Nation citizen has a denial or deferral? In other words, you send a letter to the patient. Could you communicate either in hard copy or electronically with the Cherokee Nation Health Group and tell them this person has been denied? Does that violate HIPAA in any way? Is there any way to communicate that?
We, actually, Brett and I have done that. I've let him know.
Does it happen as a matter of course? I mean, is it something that
We could set that up. We can set that up. Yes.
And the reason I ask that is because if that happened, and if Cherokee Nation in turn had a policy that they would, on behalf of the citizen, automatically appeal that decision, I wonder if we could do that. The reason I wonder that is because the chief is enacting a policy to implement this 5% increase in the dividend. For the folks that go to Claremore, and we'll get to the policy in a bit, the folks that go to Claremore, you have to go there, be denied or deferred, and then they have to appeal. Well, some of my folks do get discouraged. Some of them are elders that they don't understand the process, and maybe they don't appeal, and I kind of worry about those folks. So I wonder if you guys tell us who gets denied or deferred, we as a matter of course send you correspondence saying consider this an appeal just in case the citizen doesn't appeal. Then it's already before your appeal panel, and then if it's approved by you guys, great. If not, then nobody slips through the cracks. And I don't know how much resources it would take on our end to do that or your end, but I am interested in that, and I think as this new policy kind of plays out, I might press the chief a bit on doing that and maybe ask you to do that as well.
Be glad to sit in on that.
Okay.
Absolutely.
All right, I appreciate it. Thank you, Madam Chair.
Councilor Byrd.
We're talking about funding. In years past, the 5 tribes, when they were functioning in full force, that was the vehicle, Dick, that they were using to advocate for more funds. And they would make frequent trips to Washington, D.C., not only for health care, but also housing or education. And that vehicle, needs to be put back in place to answer some of the concerns that you guys have.
Need some help, yeah?
Yes.
Councilor Walkenstein.
Do we have something like that in place already with the 5 tribes? I mean, you guys have a group, or is that resolved?
We don't. No.
So when you guys try to advocate for more money to your area director, it's just Cherokee Nation alone?
We go through, no, what the 17 tribes on our board are aware that we have this funding shortage. Okay? I can't direct, all I can do is go to the area director and voice that we are short funds and how short we are and give him evidence of that. We talk about in our board meeting about the tribes, those 17 tribes that have lobbyists stepping up and lobbying on our behalf. And I understand that, I assume that that's happening on our behalf, outside and away from me, because I can't direct that board to do that.
Thank you, Chair.
Any more questions? Okay, thank you, Mr. Bowden.
Thank you.
Thank you. Next is Cherokee Nation Health Services, but I don't know who's representing. Oh, Jeff Sanders. Come forward, please.
Good morning.
Morning.
Unfortunately, I'm here today because I was in the right meeting at the wrong time. I don't actually have any type of a formal or written report for Cherokee Nation as a result of that, but I am actually here to field questions if we have anything, and I brought Brett Hayes along as well. I know contract health within Cherokee Nation, is usually an issue as well. So at this time, if you guys have any questions, I'll try to answer what I can. I do have knowledge other than pharmacy and contract health as well, but not quite as much.
Okay, Councilor Hoskins.
Thank you, Madam Chair. I guess I'd pose the same question to you and to Brett that I posed to Mr. Valier, which is it possible that IHS communicates a denial or deferral to Cherokee Nation? Cherokee Nation then communicates an appeal to Claremore on behalf of the citizen. Do you see any roadblocks to that? Is there any problems with that?
That's going to be a good question for Brett.
That's what you wanted to do?
It's possible. I don't know how practical, because part of the good thing of the appeal is, as a patient, I can express how that lack of the referral being approved is impacting my daily living conditions. And a lot of times that's something, oh, I didn't realize this or that, or so that can have an impact. I think an administrative, I don't want to, like a pass-through appeals, it's just going to be like a rubber stamp type thing. It's going to have the same information.
Okay, so the patient, even if Cherokee Nation is lodging an appeal on their behalf, it's nothing more than saying, take another look at this, denial or deferral. The patient's free to still send in, hey, this is my quality of life's at stake here. This is what's happening with my children and my family situation because of this. So they can still do that. But I worry about, and we've all had these constituents who've said, I didn't understand the process. Maybe they're an elder. I've missed my deadline. I've been denied so many times. I thought, what's the point? And I think about those folks, and I think, if we did that as a backup, then IHS would have to look at the appeal. They'd have to deny it, and then those folks would be in a position to get some of this 5% money. So I don't want to supplant what a patient could do, because they can do it better than we can. They can articulate it better than we can. But I do want to take care of those folks who didn't do it because of frustration or lack of understanding. And I just wonder if it's not going to cost us a lot of resources, then maybe we should do it. Maybe we should think about it.
And when you mentioned it, I was thinking about it.
Okay.
It's something to think about. I agree. Because there is a frustration, and we would basically start that process for them. It could be we'd have to sit and talk about it.
Right. And the 5% increase is wonderful. It's made a big impact on folks. But the thing about it is that they've got to go through a couple of steps, the folks that go to Claremore, and that's not a problem we can immediately fix. But until we can fix it, let's do everything we can to make sure we get those folks in line to get that funding. But I appreciate your all's support on that. Thank you. And we can visit about it again. Thank you. Thank you, Madam Chair.
Next is Councilor Walkenstick.
I have a question for contract
Tell
too.
me the stuff here, Brett.
What's the process if, say someone gets in a car accident and they're severely injured and they get rushed to Hillcrest or somewhere in Tulsa, and it's a Cherokee citizen, but that person doesn't have time to get the process for contract help and those bills racked up, do we have something in place for that type of emergency?
Well, that kind of situation is considered an ER call-in, an emergency room call-in, and they have 72 hours, them or their family, to call it in to somebody. I mean, I take a couple of weeks. Everybody in contract help takes them. We have a form we fill out, and that initiates the referral. In the case that someone's incapacitated, that can go to up to 30 days. What doesn't work well is when they get a bill and then 6 months later they call in, and that's well past the timeline we can consider for approval.
So 72 hours is the deadline to call in?
That's in the IHS policies nationwide.
Okay. All right, that's it. One more question. One of my constituents went to see a doctor at Hastings, and they said that this person needs to go get a stress test to his heart or whatever. And I guess he had went to Hastings and a few other hospitals, and they said that they don't do stress tests and that he needs to go, they need to outsource him. Do we have a cardiologist or something on staff in our healthcare system? Do you know?
We have contract health providers at cardiology.
So that individual has to go through contract health.
But we do stress tests at Hastings.
At Hastings,
We do?
yeah.
Mhm. Like a treadmill type
Yeah,
stress test, but not a chemical. We
Right,
don't
not
do the-
chemically induced
We don't do
stress
the
tests.
chemically induced
No.
stallion, but
Yeah,
that's done at Tuckahoe City through Cherokee Health Partners.
Okay.
So it's a contract health referral if it's not the physical, stress. Like somebody young and that they think could actually do the treadmill test, I might go, they'd say, you need to do the treadmill. You're not
Okay.
gonna.
So do we have a cardiologist though in our healthcare?
No, but that
No.
test is then read by a cardiologist. We send it out to be
Okay.
read. It's a function in Hastings generally.
Okay, that's all. Appreciate you guys. That's all.
Okay, next is Council Lady Hargis.
Yes, I had a 71-year-old gentleman call me the other day, and he had been to Mankiller for an eye exam. And he picked out his glasses, got his prescription, picked out his glasses, and they figured it and told him it was $60. His out-of-pocket was $60. He gave them his insurance card, and they then told him, they refigured it and told him his out-of-pocket would be $199. So what's going on with that?
So Brett knows the answer to this one.
It's part of, I assume it was through our VSP,
Vision Service Program,
as part of our Blue Cross and Blue Shield plan.
was it a patient?
Yes, it was a patient there at the Mankiller Clinic. He's 71, but he's covered on his wife's insurance. And
Well, and that's we want everybody to use their insurance because we're the payer of last resort.
yeah, I mean,
I'm thinking that, I'm trying to remember back, about 4 years ago, I've started to try to impact this. Because, I had the same scenario, and it was bigger numbers, and it baffled me. So we've been working, we just got to get the insurance companies to accept. Part of the problem is we have through NSU, we have such good rates with what we do get. Those are rates that they extend to us as a partner. And then when they have, because they have insurance, they then have to use those rates that the insurance company utilizes. And they use, like Jeff's familiar with pharmacy, average wholesale price, they use certain categories. And so that's a thing that we've been dealing with for years, trying to tackle. I don't know.
I understand that, but I know when they visit a doctor, if you have insurance, you don't have to pay your copay, and the health clinics bill your insurance, and that's what they accept as payment, what we gather from the third party. So why is that not in the vision?
Because of our vision plan. It's an insurance policy issue. And I'd be happy
So
to,
we
when
need to
we
look
get a
at
new
that.
executive director, to initiate that again, because, I thought it was something easy to fix, and apparently it
Yes.
wasn't.
Well, it
It's
needs to
still
be
there.
fixed. So when we do get an executive director, we need to address that.
Yeah.
That's on my list.
I think many people have tried to use the plan even if.
Because it's going to cause a lot of people not to use their insurance, not to even tell you. And if they don't tell you on the vision, they're not going to tell you on the health part. So that's going to take that away too.
Yeah, it's counterintuitive. It
Yeah,
doesn't,
absolutely.
it makes you scratch your head.
So we need to look at that.
Okay.
Okay, Councilor Lane, you're next.
Thank you, Matt. Do you know anything about the summer WIC program for the 5 counties?
I do not. I would have to defer that back to our new executive director.
I'd like to have somebody, I know we're doing it for 5 counties, I've been told that a couple of times. I'd like to find out why we're not doing it for 14. Nobody's been able to answer that for me.
Okay.
Summer
Yes.
WIC.
Summer week.
It's probably in that report you have that I haven't had a chance to look at. We can get you an answer.
Councilor Watts, you're next.
Thank you, Madam Chair. On the draft CHS policy, how are you defining low income? Because that's kind of an ambiguous term. And then what is necessary dental procedures? I mean, necessary to me versus necessary to somebody else, that's a broad, I don't see how this can be adopted without some of these things.
Better defined. Brett, you may know more on this too. You know, a necessary dental procedure, in my assumptions, it would probably be something that needs to be done in order to make an assessment. I don't know.
And maybe it's because I'm not in the medical field, but if that's a policy, that's very ambiguous if I'm trying to figure out how to fairly spend Cherokee people's money. So to me, if this can't be adopted without better defining low income, what does that mean? Is it a certain standard? Because we already know we have multiple standards of what low income is in the Cherokee Nation, depending on which one you're looking at. Then what is necessary dental procedures, and who decides that? Is there a line that's drawn? Then even in that same section, additionally, these funds are allocated to cover necessary dental procedures that our health centers are not able to provide. Is that part open to all incomes, or is it only the first one is 100% of the cost of dentures for low-income Cherokees? And does that defer that if you're a millionaire, you might get a portion of it covered by the Cherokee Nation for dentures, but not all of it, only if you're low income? And the same thing on optometry. I have the very same questions. And then to the other council people's questions, what is that communication path between Claremore Indian Hospital, Cherokee, Contract Health Services, and us? And what are the triggers from the patient's side or citizen's side? And then on C2, these patients cannot be back to work eligible. My question is, what does this mean when many are served by clinics and contract, or is it, no, it's the first part, I'm sorry. If they were receiving care at WW Hastings to maintain an equivalent standard of care, how does that equate if they're being served by the Cherokee Nation Health Clinics or Claremore Indian Hospital in comparison to Hastings? Because that's apples and oranges, correct?
Well, I would think, again, it sounds like, Carrie, you've got a lot of questions, and I'll be honest, I think the best way to handle those is maybe put those in an email to myself and Brett, because it's going to take more than just us figuring those out, and we need to bring in the other disciplines as well.
And I will do that, but this is a policy that's going to affect a number of people,
Absolutely.
so it needs to be done in the light of day.
Sure, absolutely.
Thank you. Thank you, Madam Chair.
Councilman Byrd is next.
Back to the 71-year-old person that was trying to get the eyeglasses. When we first negotiated the motor fuel money, that's where the funds are supposed to be spent, dental, dentures, and eyeglasses for the elderly. And I think this is an insurance issue you're talking about. We want our tribal members, if they have insurance, to utilize that so we can attain better professionals at our clinics and hospitals. I think that's what you read into there. Is that correct?
Yeah, it's, we don't want to create a disincentive to utilize a benefit we've given people. I mean, usually the bigger problem is with our Blue Cross and Blue Shield, so
Yeah.
that's, most people have VSP through that.
But we still have that in place as far as taking care of our elderly with the motor fuels money, unless it's been amended in the past few years from the
As
council.
far as I know, it's
Yeah,
nice.
I mean, it's not technically, it's all kind of, it's not motor fuels money anymore. It's kind of all one big general fund type funds. But yes.
Okay.
And that,
Thank you, Madam Chair.
Councilor Jordan.
Okay, my question deals with this entity called Healthcare Partners. I would like to know who they are, who runs them, what's the agreement we've got with them, and next month I would like them here.
Okay, you got that down?
you mean Cherokee Health Partners?
Cherokee Health Partners?
Yes.
Okay.
I would like to know who the board members are, and I would like to have the board members here, because I have some questions about how this all came about, what their role is with Cherokee Nation Healthcare, and I expect that I'm going to need some assistance, maybe from our financial officer in looking into some of their paperwork, their books, and whether we're doing any sort of audits, and where that figures into the health program.
Okay. We will certainly get that investigated for you and hopefully have some folks present. I will pass this along to our new executive director as well.
Yeah.
I think she should be present at the meeting.
And most importantly, I'd like to know what their agreements are with us. I would like to see the actual agreements. I would like to know how how it came about, how they were formed. Are they an LLC? Is that LLC between us and the city hospital? Are they a corporation? Is it a tribal corporation? What kind of paperwork? What kind of agreements? What kind of money is involved? I have a whole host of questions, but I know it's not for you two, so carry it back to your folks and tell them to come loaded with being able to answer some of those questions next month.
Okay. All of them geared towards questions of transparency.
Thank you.
I have a comment along the same line. 4 years ago, Cherokee Nation came down to Sequoia Memorial Hospital at Sallisaw and signed a contract with them to be a preferred provider, which their contract meant that they would accept Medicare rates down there. And they were going to send them a lot of business from that end of the nation for MRIs and sleep studies at Sequoia Memorial Hospital. And that was really convenient for all the people down there that didn't have the money or the time maybe to come to Hastings. Well, now, I was told by some of the providers out at Redbird Clinic that they have been instructed to no longer send anyone to Sequoia Memorial Hospital, to direct everybody to Tahlequah City. And I went to a meeting yesterday at the Chamber of Commerce, and I saw the CEO of our local hospital down there, and she said, I really need to talk to you. We're not getting any referrals anymore. And I think this has got something to do with the healthcare partners and all of the people that down there that have been taking advantage of the agreement that we originally had with Sequoia Memorial are now, set up here. So I would like to know the same questions, the answers to the questions that Councilor Jordan had. Thank you.
Okay.
That's my comment. Councilor Watts, you're next.
Thank you, Madam Chair. Just to clarify, because it may be an area and I may have additional questions to Councilwoman Jordan's, but is that the home health?
No.
That's not the, okay, because I was trying to understand some information I'd obtained yesterday, and so that's what I needed. Thank you.
Do we have any more questions? Well, I have one, since we've got the Director of Pharmacy. At the Redbird Smith Clinic, the only way that you're supposed to get a refill is to punch in your Social Security number and your prescription number over the telephone. A lot of our elderly that are 70 and 80 and up, doesn't have to necessarily be elderly, they're not able to do this. And I understand from talking to, Three Rivers, that they still take a voice recording the way it used to be done down at Redbird. That you can just tell them, I need whatever your drug. You don't have to go through the procedure. A lot of the folks are just real shaky and real nervous and they can't do it. Is there no uniformity from one clinic to the other on how you go about getting your refills?
Currently, there's a lack of uniformity, but it's because we're in the process of moving all of our pharmacies over to the same telephone operated system, which is Audio Care. We do still take phone calls from patients who are unable to do such. Some people have rheumatoid arthritis and are unable to touch phone keypads. And we still take phone-in calls for those patients. It's not a mandatory thing, but it is preferential for all those patients who do have the ability to use that system because it aids the efficiency of the pharmacy system considerably. And as we progress in our system and continue to grow, part of this Audio Care and the refill center and some other areas within our health system are all put in place to help serve the patients better. Eventually, we would like to actually have all of those patients who are using audio care, those orders are going to go directly to the refill center and not even have to go through the pharmacy, which affords us more time to spend with the patients that are actually in the facility. I hope most of you here, have probably seen some improvements. I know we've got a lot of good comments from patients who are utilizing the system as well. There is a learning curve, and I think that was one of the areas where we maybe we're a little deficient in it at the initial startup of this system. But eventually we all will be using audio care.
Councilman Jordan.
And Jeff, since you're here and you're
Sure.
very acquainted with the pharmacies at your area, would you think about this idea? There's been a lot of talk amongst the council about why can we not do a 90-day refill versus a 30-day refill. I know this is a very important issue with our chairperson here. I would propose to you to consider a 90-day refill for the totally non-insured patient and the insured patient where the insurance would cover a 90-day refill. That would only leave the area of 30 days for the patient that has insurance that will not pay for a 90-day refill and will only pay for a 30-day refill. Is that a compromise that could be considered for the 90-day refill issue?
I'll be upfront and honest with you. I mean, that's probably one of my poor qualities is I'm not going to tell you something you want to hear, but I'll tell you the way I see things is I, for one, do not want to silo our care. And siloing by I mean having one group of patients receiving one benefit and another group of patients receiving another benefit, especially when it comes to pharmacy services. Now, I've met with Counselor Lay a couple of times and met with Chief Baker as well, and I know there's still, they would like to see some of the patients, elderlies is where we're at right now, our elders, maybe go to a 90-day supply. And, I've agreed to try to look into it and see what would be the best methodology for us to attempt to do that. Albeit some of the data that we had pulled earlier just to look at the financial loss, is about $3.4 million if we were to
Do it totally.
No, if we were to cut from 65 up. To do it totally, we're looking at losing 15 million. We would basically lose, if everybody went back to 90 days, we would have a very small group of billable insured patients.
Jeff, where is our loss? Where is the $15 million loss? Is it the loss on the insurance and Medicare and Medicaid?
It's private insurance, Medicare, Medicaid. Yes, it's all combined.
And your preference is not to, I think you said, silo them off, where we could do the totally non-insured. We pay for every bit of their pills anyway.
Right.
The insurances that will cover 90 days, that's just a pass-through. We're not losing any money on that either.
Yeah, well, and the problem with that, Councilor Jordan, is the fact that there are so few insurances that will cover 90 days within our health system. I can actually count them on one hand. And that's the big problem we run into is we're not privy to some of the privileges that private sector pharmacies have. And this, it hasn't been a short process for pharmacy. It's something that I actually started in 2005 as an experiment, and it was done at Redbird to see what 30 days would do for us and for patients. And it did increase our collection significantly, but along with 30 days, the thing that we need to keep in mind is there are also some health considerations and factors that we reduce as well. We improve the patient's health by having a smaller day supply. And that's been shown every time we've attempted to do this. I have actually a packet of information that I gave Counselor Lay at one point when we were speaking that I could provide to you guys, by email if you'd like me to do that. That gave all the pluses and minuses involved with 90 days. It's a double-edged sword, and I'm here to do what's best for the population and what our people, patients would like us to do for them. But once again, I would like it to be within reasonable parameters as well.
Well, I for one would like the packet of information. I don't
Sure.
know how many other.
I'll be glad to supply. I'll get the list from from somebody here.
Well, you could
and-
send it to Shelley or
and she
Dale,
can
and they can
distribute it.
send it out to everybody.
Sure.
My
absolutely.
last question is, when you were talking with the executive branch about maybe providing the elderly with the 90-day supply, was that age 55 or 65?
Well, we didn't define an age, and that's where I kind of have an issue. I hate to be the person to define that age, but it was 65 and up is where the $3.4 million loss is going to be realized. And Councilor Lay had asked me to try to do it for a couple other age ranges, but unfortunately we've had some problems with our PMS system, and I cannot get accurate reporting right now for POS collections. And I don't know when that will be repaired.
Well, when that does get repaired, could you calculate that for 55 or not? I just am curious.
Sure.
Thank you.
Sure could. You bet.
Okay, I've got another comment here. I'm really interested in this subject. You said that it provided better health care to only give 30-day supply. Well, the providers that I have talked to has said that, especially a lot of their patients on high blood pressure medication, when they would come in for their appointment, they maybe have been out of it for quite a while because that's something that you don't feel the direct effect exactly when you quit taking it. And they'll say, well, I only got a 30-day supply and I had too much trouble, come up here every 30 days or call it in, and people are going without their medication, whereas they were used to getting it in the 90 days. And I would also be curious to know, my family is covered by Health Choice, which is one of the largest insurers in the state, and Blue Cross and Blue Shield. So from my first-hand experience, I know that both of those companies give 90-day supply.
They do. Mm-hmm.
And is it Medicare and Medicaid that only give a 30-day supply?
No, the same insurance companies that will afford a private sector a 90-day supply will not afford us that same option. That's just one of the caveats of Indian Health Service.
You mean if I take my Blue Cross and Health Choice down to the Southside Pharmacy, they'll give me a 90-day supply, but they won't to the Cherokee Nation?
No, ma'am.
Well, who negotiated a contract like that with them?
Well, we have the negotiation of those contracts really falls outside our parameters. And let me back up a step. In 2007, my very thought was, well, I'm going to approach the insurance companies, and I'll, say, and I had it laid out in paper. We were going to let them be more profitable, but benefit us greater by letting us all do 90-day supply for all the insurance companies. Well, unfortunately, we are a very small player in these insurance companies. Comparatively speaking, when we look at the number of our insured patients versus their populations of tens of millions, they're not very amicable to accepting our suggestions of letting us bill for 90 days. And that's where it stands. Todd Hembry actually is going to follow up with that and see what maybe he could have done as well, which would be great. But that's where we are with 30 days and 90 days right now.
I do understand a little bit about insurance companies because I know the people who work in the casinos, their Blue Cross and Blue Shield has much greater benefits than the Blue Cross and Blue Shield that we're on. They're totally different. They're not the same, so they were negotiated differently. But it really is a hardship on the elderly. There are mix-ups in the mail on people getting their prescriptions by mail order. I do, but my sister and I called ours in last week, same day. I got mine in 2 days. She's still hunting hers,
Yeah, some things are beyond our
I had a
control,
constituent
unfortunately.
call me from Muldrow, and he said, I got all of my medicine plus some other gentleman, and he had called this gentleman in the phone book 2 or 3 times at different, I won't use the man's name, but those were all deceased, and he had tried to call Muskogee and tell him, and they just got snippy with him, and he was trying to help him out to tell him that he sent the wrong man's medicine plus his medicine. He was trying to help this gentleman get his medicine that was lost. Well, I sent off an email, and Dr. Nolan emailed me back. They were well aware of it, and they had it all taken care of and handled. So there's all kinds of mistakes that are made.
Well, unfortunately, I'm not going to hold anyone to the highest level of infallibility. Sure, error's going to occur. I don't care where you are. I will say for Cherokee Nation, you guys may not be aware of this as a group. Our error rate is probably one of the lowest in the country. Out of 300,000 prescriptions, and this is, I'll just speak from the refill center, 300,000 prescriptions that have been filled out of the refill center so far, we've actually only had 2 errors. And in the retail segment and the other mail order segments, those numbers are considerably higher.
Well, I
They
will
unfortunately
say,
happen, and
yeah.
I'm not going to excuse them, you know, but
At Redbird Pharmacy, they've got a lot more congenial people working in there now than they
Yeah.
used to have, but I was coming home with my husband and he said, my medicine bag feels awfully heavy and it was only supposed to have 1 prescription in it, and he looks in there, we've got all this medicine for some man that we do not know. We go back up there and the door's locked and he bangs on the door and they finally let him in and he says, takes it around there, and I've got Mr. So-and-so's medicine here, and it's just like, oh, hon, well, so what, you know? And they take it back.
well, we don't take them lightly or should not be.
I know, but I'm just telling you the way, what happens to the general public who walk through the door may not be exactly what you think is happening. So, I do appreciate all their hard work, and it is a good system, basically, for everyone, but when people, me as well, they resist change and they don't like it.
Sure.
I have a 92-year-old aunt that always has a complication about her medication every time, every month, and someone has to go get it for her, and she has to be counseled, and on and on and on. And it was just so much simpler when it was 90 days. That's all I've got to say on that subject. So.
Okay, and for some, you know, you're probably correct. But, you know, one of the things I think we lose focus on, too, is if we have patients who are unable to pick up a phone and call and then go pick up a prescription out of their mailbox, to me, that's a symptom of someone who needs a higher level of care. You know, there's more to the problem than just the prescriptions. It's actually that patient is not able to really care for themselves. And even if they got 90 days, could they properly take it? You know, we probably should have someone assessing them even further for, I think, a greater need of care.
Councilor Jordan, did you have anything else?
We just want to let you know, Jeff, we appreciate you coming down.
That's okay.
You're a friend of this group, and we
Thank
don't
you.
mean to be harsh with you, but
No, no,
we
and I
do
understand.
have some real questions that we want you to take back.
Well, absolutely. And,
Whoever the next person is coming.
well, and thank you. I mean, without questions, we can't solve problems. And I totally agree with that. Thank you very much.
I do want to say that at Redbird Smith, the 2 front ladies that are at the window are so sweet and congenial. Even if there is a long wait or a mix-up, most people are happy when they walk out the door. So we do have a great improvement over the kind of people that we did have working there. At least they smile at you. So Councilor Garvin has something next.
Thank you, Madam Chair. I had a constituent call me yesterday, and he was trying to get help. He originally went to Hastings and referred to the city, Telequil City, had a blood clot in his leg. And they told him he'd have to go through Creek Nation, and he did that. But Creek Nation is out of money, according to him. So what's the next step as far as getting help?
Well, it varies by residence, but
He's in Muskogee County.
well, Muskogee County is split, you know, all the outpatient is ours, whether it's Haskell or Weber's Falls, and all the inpatient is theirs, whether it's the same.
But they're out of money, they said.
Right, and this program, the 5% program for people living in the tribal jurisdiction, that's where it would come into play. That's where we have to get down into looking at the specific address and, you know, going in the GIS system, looking it up.
Okay. I guess I need to get with you later
Okay.
on.
Yeah.
Thank you, Madam
Better
Chair.
be a one-on-one.
Ms. Fisher.
I have got, yesterday I received 18 complaints on drop-in doctors at Stillwell. 18 of them.
Holy smokes.
Oh, I was upset with you all.
Wow, I will certainly make sure that our medical director is aware of that.
Thank you very much. I
You
appreciate
bet.
it. Thank you.
Well, I have one more comment because he just reminded me of something. This new 5% that we're bringing forward, which, you know, like 60% of it is going to be for the people who have exhausted all their appeals with the other tribes. The people that brought it to us, brought it to our attention now, things that happened last year, now I'm being told they're just out in the cold. I mean, this is starting from now on, and if this happened last November and they've exhausted all their appeals, and although they just got their final appeal letter that it was denied from Creek Nation last week, the way I'm interpreting the policy, there's tough luck for them if it had happened once we get the new policy going. And I think it ought to be retroactive back to a certain extent to all those who apply, because we know a lot of people from Weber Falls and this particular place I'm talking about, case, what happened in Tulsa. But all of our constituents, friends, relatives, although Sequoyah County that I represent down there, but I'm representing all of District 3, and a lot of District 3 falls into that no man's land of the Creek Nation who always are out of money. And I would like to see some proposal as to how we can serve these people that brought all of our attention to the problem, and now they're going to be left out, in the way I interpret it, and the emails that I have received from Dr. Nolan.
Okay, we'll pass that on to the new executive director.
I'll be passing it on to them myself.
Yes, I'm sure. She has a big plate when she comes on board.
Okay.
You get that. Okay.
Any other questions? Oh.
Ben, are we coordinating this with the Muskogee Creek Nation? You know, they have new leadership, probably a new health director. Have we set a time to meet with them?
You know, Joe, I'm making the assumptions that we are. Brett may know better the answer to that at this point.
And I know we're asking you guys a lot of questions.
Sure, well, at least they're coming out.
Okay.
This would be a good video for the new ED to watch.
It's just something I thought, you know, with the new leadership, there may be, this is something that we can address and resolve.
Sure. And they're in the same boat we are.
Sure.
They don't have an executive director of health right now either. So.
Okay, all right, well, that's understandable. We can only improve.
You bet.
Thank you, Madam Chair.
Yes. I think that's all, Mr. Sanders.
Is that it? All right.
Thank you very much.
You bet.
Thank you for being here.
Thank you.
Looks like we're getting behind here just a little bit. In old business, we have a resolution about the concerns the funding of Cherokee Nation Home Health. We've got a recent report here about both of these resolutions. And Councilor Fishenhoff.
But when we start in on this, I would like to have Doug come forward, because I've got a few questions for him. I asked him to run some financial.
I move for approval.
Yes.
Before we get into discussion, we need a motion. I move for approval.
You have a second?
Second.
Okay.
I can make a motion to table this.
Second.
We already have a motion for approval. Did you have a second? You seconded
For discussion.
for discussion?
Tabling takes
Yeah,
precedence.
table takes priority.
Okay.
So I can make a motion to table this.
And who was your second?
Here.
Carol, okay. We need to have a vote. All in favor of tabling?
Aye.
Aye. Roll call. To table.
Bill England,
Yes.
Jack Baker,
Yes.
Joe Byrd, Julia Coates,
Yes.
Jody Fishenhop,
Yes.
Meredith Fraley,
No.
Janelle Fulbright,
Yes.
Don Garvin,
Yes.
Frankie Hargis,
Yes.
Chuck Hoskin Jr.,
Yes.
Hannah Gloria Jordan,
Yes.
Lee Keener,
Yes.
Dick Lay,
Yes.
Curtis Snell,
Yes.
David Thornton, David Walkingstick,
Yes.
Kara Cowan Watts.
Yes.
We have 14 yes and 1 no.
So this is tabled. Okay, we'll go on to the next one. And it's a resolution authorizing reimbursement for non-funded and underfunded home care services provided to Cherokee Nation by Cherokee Nation Home Health Services.
I move for approval.
Second.
Okay, let's have a roll. All for approval.
Are
Karen?
we gonna have discussion?
Discussion?
Yeah, let's discuss.
Okay. Yes.
I like this. Do I get the floor?
Yes.
Okay. Can we just real quick? How does this industry of home health care average about 50% of the gross profit, and we're only at 26% gross profit?
Just, could you allow me a moment to kind of?
Yeah. Go
All
ahead.
right, appreciate that. Many of the things that I hear discussed every day or every meeting I come to here, the med issues, getting the meds, helping people get meds, that drives a lot of our costs because the nurses meet those needs where there's a gap. So we do a lot of extra services for our patients that other home healths won't do. We may go to Hastings on their behalf. We may cut the pills on their behalf. We're going to do a lot of these services others don't do. The other thing, what we've done here is we run 3 departments in our home health. We focused on one department, which is our home health department. And in that department, we took on a lot of underfunded patients, Medicaid reimbursed, Blue Cross Blue Shield reimbursed, so forth. So we only got half, or $68 a visit, for doing those services. So when you see the private sector at $111 a visit in your report, they do not do that. So we took that on for Cherokee citizens and community members. That's what really drove our cost past the norm.
Down to 26.
Yes, sir.
Also, how do you explain the total salaries of revenue being at 80%, while 15% of administrative costs? So, I mean, you get 5% revenue.
Okay. Again, that's one department, and that's what we're being measured against, the Medicare Home Health. The other department, which is our Advantage contract, is super labor intensive, and that's where a lot of those salaries come from. However, what we did in the last 2 or 3 years to try to help our people out, we developed kind of a transitional care program. And so we put nurses in the field working directly with community members to try to help them get on services for things, so we weren't reimbursed for that activity. An example, if someone would call me and say Mrs. Smith needs help, then we would drive to her home and go do what we could do to help her get a service, and it may not be ours.
Well, the state average is about 58%.
That's correct.
And ours is 80%.
But again, you're only looking at a home health that does Medicare only. Our home health does the Advantage waiver program.
What's the state administrative cost? Ours is 15. What's the average administrative cost for a program like this?
Well, it depends on your setup again. You can get it down as low as 15 or 20. I have a friend who has a home health in Oklahoma City whose average visit is only $80 per visit. He's driven his cost that low. But again, it's what do we want to be as Cherokee Nation Home Health and our nurses, and we made the choice to be a service industry to our folks. And taking the low reimbursement and providing the extra service drove our costs. So what we've done in a slow fashion in the last year and a half and last 6 months is we've canceled our Blue Cross Blue Shield contract. We no longer admit skilled Medicaid patients, and so those extra high-cost patients we've done away with, so now they're not, more than likely, not getting services.
And was we doing services to non-funded, non-Cherokees?
From time to time we have, sir. We have helped community members.
It's hard to make a profit when 95% of your revenue is tied up in salaries.
Very difficult.
Yeah.
If you look at the 3 years that we looked at, there's $14 million in gross billing. $560,000 of that went to a write-off for underfunded and non-funded patients. And so we lost $181,000. So we do away with just not taking care of people who don't have adequate reimbursed. We're reimbursement, we're profitable.
Okay. Thank
And
you,
that's
Madam
what we've
Chair.
done.
Counselor Watts, you're next.
Thank you, Madam Chairwoman. There was no financial report submitted for the month in our financial management. And then this is the first time I've seen this report. I got it when I arrived today. I've had no time to read it. It is not that I am not supportive of what you guys are doing, but I still lack, if we're gonna spend tribal people's money, we lack a comprehensive report, whether this is a one-time issue or if it's a projected, like, maintained program. You seem to continually acknowledge we're not gonna be able to operate as a for-profit, which you're set up essentially today, or zero profit. So if we're gonna have to continually subsidize, we need a long-term plan, and it needs to be coordinated with health. So it's not that I don't support what you're doing, I'm struggling that I would be fiscally irresponsible, and I would not be doing my oath of office if today I voted on this.
Again, we have stopped taking insurances and state Medicaid money for skilled services that we've had to write off. So we're only taking the higher paying patients, which are Medicare, in our home health department. And that's the analysis you have. It's just for 1/3 of our business. It's not for the total package. And so we have stopped doing those services. So if we don't have a public health nursing system, a combined effort to help out these folks, then they will be without.
But Rick, why don't you have a financial report for this month?
I was aware it wasn't submitted, and I had it submitted to finance, so it was submitted later. Too late for this meeting. I was made aware of that.
Okay, because I just can't, if I don't know, like, the whole package and what's going on, it's...
Again, we're only seeing part of the problem. And a lot of the problem is who we are. Let me get that, who we are, because you guys drive and campaign in your areas. Only Delaware County's barely 20% Cherokee, just a little over. So we're Cherokee Nation. We drive all over that county. We're not a home health that can market 100% of the county. So we travel more than all other agencies. You can't run us through a non-Indian filter and come up with an answer that works. It's not going to happen. So, but we can give you that if I know where we want to go. If we want to go strictly for profit and drive costs to the bottom in services, we can do that. If we want to be of service to the people, then we can do that. I just need to know where we want to go.
Counselor Jordan, you're next.
Rick, Rick, I'm interested in who referred these patients to you that were non-funded or underfunded.
They come from a variety of locations.
Well, tell me the variety of locations.
Sometimes we get them from Hastings Hospital. We may get a call from that facility, and we go up and visit with a patient, and we will help that family out. Sometimes we get them from Contract Health. Sometimes they come from public health nurses. They come from about every facet of Cherokee Nation. A lot of times what we attempt to do for a young adult, they come to us with no funds, and then we try to get them qualified for Medicaid so we can get reimbursement.
Well, when exactly did you stop taking the underfunded or non-funded patients?
It was a process. Last January, we started slowing it down, and then on September 30 of this year, we shut off Blue Cross Blue Shield and Medicaid. We limited to 5 miles from our offices because of the travel.
Rick, how are you set up? Are you set up for profit?
We built a healthcare, home health, to provide good health care and create an atmosphere where our employees could enjoy their work.
Is home health care an industry that is set up for profit?
Our home health isn't, but industry-wide, there's big profits being made right now.
When this home health care was set up, was it set up as a for-profit entity?
The documents I have in 1981 said the council set it up as a not-for-profit home health agency.
Are you in the business of trying to make money?
Pay bills, yes. Make lots of money, no.
Well, are you paying your bills?
Right now, we're cash flowing right now. We've got ourselves back, since we've done away with so many underfunded patients, we're beginning to cash flow. So we haven't had to draw down any line of credit unless.
You understand, this resolution is asking us basically to give you, how much is it? 174,000 or 250,000? What is it to cover your losses?
For the underfunded group, it was 264.
You want this body to give you $264,000 to cover your losses. Is that what you're saying?
Well, that would be the services that we provided to non-funded Cherokees and underfunded Cherokee citizens. And that would be a big help.
See, it appears to me that your program doesn't know what its objectives are. I've always understood home health care as a profit-making entity. You're standing here telling me it was not set up as a profit-making entity.
That's all of my documents say nonprofit organization.
This entity, in my opinion, should be over under C&B. It should not be part of the government entity. And I, too, cannot support this in the form that it's in today, given the fact that I believe home health care should be making a profit. And for some reason, it's not making a profit. And it's not made a profit in a long time. Now, it may be that we're sending Rick Richards mixed signals. I don't think those mixed signals were coming from here. I think that most everyone in this room thought this was a for-profit making venture. And for some reason, it's not making money. Now, maybe 20 years ago, you were given different guidance, but that wouldn't have been you either, would it?
No one has ever really given me guidance.
Well, but this non-guidance has put us in the negative. And I think at this point, this body is tasked with, do you want to continue down this road where we supplement this program every 3 or 4 months with an infusion of $250,000 out of our services that are needed for other programs? Or do we send this program to CMB where they can clean it up and get it on a profit-making road? That's where we're at, folks. We've knocked this around for months now. This particular part needs an up or down vote today. We need to send a signal. Do you want to continue down this road? Because we've already given Rick money twice before to cover this situation. Now we're coming back to the well for a 3rd time. This is happening all too often. I don't know what the problem is. This here, if I believe this report here, which I have no reason not to believe, is an indication of mismanagement. And Rick, I don't mean to be harsh on you, but that's what this report indicates.
And it's very accurate.
This report tells us we've had mismanagement in this program. Now, it may be mismanagement that's unintentional, because it may be that this gentleman has not been given guidance on what kind of program we expect him to operate. This needs to go to CMB. We need to vote this down. We need to send this program to CMB and let them clean it up, because they're our business arm. They're not part of our government. They're in the business of trying to make money for us. This is where this program needs to be. They've already got Mobility Plus. They're moving into the health field with their IT programs. This program needs to go to CMB, in my opinion. And I can't vote for it. I can't support it today. And it's not that I'm against helping the Cherokee people, but we got to find another way to do it.
Madam Chair?
Yes.
I'm glad, after so many years, to get to have this discussion. It's a relief to me, because as a citizen of the Cherokee Nation and as employees of that are citizens, we put everything into helping our people the best we could without any resources. The last 3 years, we've got 1 in 4 of our referrals from Cherokee Nation sources. We work very hard to market and educate those sources, and that's where a lot of this money goes, to push that in addition to services. The other thing I just want to make sure we understand is that when we move into the profit area, this is what our people will say. You're just like the other guy, what good are you? And that's what we've heard for years in our home health. If you're like everybody else, then what good are you? So we done the best we could to provide that service. So I do appreciate the discussion, and I'm looking forward to moving whatever direction the council and executive branch want to move.
Councilman Fisher.
Okay. When you was talking about non-funded and underfunded, how many of these patients is in the census now, your census?
About 10. We've reduced that down.
How much was it at one time?
We could have been as high as 30, but over the course of the last 4 years, we've probably provided service to about 400.
Okay. Doug, I asked you to look up a few things, and how did you see the gross profit margin being half the state average when I asked you to run your report and look at the financials?
Well, first off, and I know you guys are running hard and running behind.
We've got time to do people's business. We've all had that discussion already.
We have, I just want to say, Madam Chairman, appreciate your patience on this issue. I know it's been on your agenda for a couple of months, and appreciate the committee's patience on this too. Worked with Treasurer Horn, Mr. Richards, looking at the past 3 years' financial statements. It's obviously a labor-intensive company here when you're running that high percentage of salaries and benefits to your total revenue. One thing that Rick just stated, that we're looking in comparison to those industry standards, home health for 2010, which is, I believe, the year that you're looking at on the back page of the benchmarks. By the way, that benchmark report was one of the items we were waiting on. We just got that yesterday. But home health in 2010 was 73% in comparison to 58. So, although I understand that there's outreach, hospice, and home health all rolling up here, that's contributing to an 80% total salaries and fringe, 73% is home health compared to 58%. So if we do carve out just home health, it's still 73 compared to 58 of the average. One thing that sticks out in my mind here is it appears as though there's either an inability to recoup 100% of paid time for care providers, or we're paying our care providers a significantly higher percentage than the industry standard is. That is what will constitute the margin difference Mr. Walkenstick brought up, okay? In other words, if the industry average is 95% billable time for all care providers like nurses and physical therapists or whoever you're paying, or 100%, I'm not sure what the industry averages is for these services. I'm not really sure if we're recouping and billing out all the time that we're actually paying them.
How do you pay them if you cannot recoup it and bill out on them for all their time?
Well, I don't know how. You have to answer that.
You got to specify the department. Each one is different.
We'll just take home health.
Home health. Well, you don't get windshield time. So we will pay our people travel time and mileage to get somewhere, where the industry may pay per visit. And so the employee receives no time for the travel. They only receive time for in the home. So the employee gets a less reimbursement and sometimes even less travel expense.
I'm still at a loss because all the other ones still make money.
I'm not really sure I understand that either, Mr. Richards, because the 73% I just mentioned doesn't include mileage.
But that's for travel time.
So you're paying for travel time that's not billable?
Correct.
And mileage on top of that?
Correct.
Why travel time on Cherokee?
It's the norm of Cherokee Nation, that you pay your PHNs, your CHRs,
But
everyone gets travel.
industry.
Again, it's the norm of Cherokee Nation. It's where we came from in 1998.
I've got a really short question. Who instructed you to provide these services that you knew you was not going to recover?
We were asked to, that's all.
I'm going to ask you one more time. Who asked you to?
And I'll say I can't answer.
Okay, I've got a problem here. Do we need to go into executive session? Step out in the hallway?
executive sessions for the tribal council.
Are you refusing to answer is my first question.
Well, you know, there's a lot of ways we can look at this.
No, I'm
If I-
asking you
if
a
I
simple
say
question. Are
you-
you refusing to answer? That's all I need to know.
I can't tell you who sent people to us.
I asked you who instructed you to take on these patients where you knew you could not recover costs.
Then no one did.
Okay. May I, it has always been the policy of the Cherokee Nation for those that present to the council, and as being the council's former attorney, to answer the questions of the council unless it were to divulge confidential information. And at all times, it has always been the policy of the former administration that people or not testifying, but reporting to the tribal council do so in a truthful manner. I think it's important that if you and I need to discuss to see if this is confidential information, we need to have that discussion. But any information that is given to the tribal council must undoubtedly be truthful information.
Okay, I would like our attorney to find out if it's confidential information and why it's confidential. Or the
Attorney
AG,
General
I
of the
guess,
Cherokee
the Attorney
Nation.
General. I want the Attorney General to find out if it is confidential and why it's confidential.
I would ask for a 5-minute recess so the Attorney General can visit with Mr. Richards regarding that question. I'm quite concerned that someone comes before this body and tells us they cannot answer a question that we've asked.
We'll have a 5-minute recess.
Right time, Dave. Gotta get time.
4. And I think Ms. Fishing Hawk still had the floor.
Rick, I know you talked to our Attorney General, and I want to know, is the life care program, is it not essentially the same thing you're doing with home health and outreach program?
Yes, I wrote it actually 7 years ago, or 5. It submitted it then because we saw the need. The need was so great, and I wrote it then.
I'm going to be real honest so I can tell the council and I can tell everybody that's on streaming video watching. Rick, I like you, but I have a problem with anybody that on their own goes out and decides they're going to start taking in all these people that are not paying. I have a problem with that. I have a problem with this, the fact that we cannot make any money off this program when everybody else is out there. I'm a nurse. I've been in the field. I know how much we get paid. And we get paid darn good, and believe it or not, when I'm a visiting nurse, I get paid a lot more than our regular nurses do when I'm traveling. And I'm not happy with this program. I agree with Counselor Jordan. It needs to go and be for a profit, because this is a money-making son of a gun, folks. Everyone sitting here knows home health makes money. And that's the problem I have with it. And to be honest, I'm going to move for a vote on this. Up or down. We need to send a message. This is ridiculous. Thank you.
My question for
Councilor Panklin.
Me? Thank you, Madam Chair. Rick, and you and I have talked about this for years, you know, about expanding it, and I appreciate you up here in front of everybody, but have you ever expanded it up into the northern area at all?
In 1995 and 96, we were in Claremore. We had 100 patients on an average daily census. And then when the balanced budget amendment hit, and there were some other issues during those time periods, we had to close that office and shrink back. And since that time, it's been very difficult to re-expand back up there. So we were there once.
Thank you, Rick. And I appreciate it, but I just see that we're funding a program that's not touching every county in the 14 county. You know, I won't be supporting it either. So.
Next is Chuck Hoskin.
Thank you, Madam Chairman. Ms. Richards, before the break, you had answered a question that caused us to take a break, which is Councilor Fishinghawk wanted to know who told you to take on those patients, and the answer started out, I can't tell you, which suggested that someone did tell you, but you couldn't tell us, and then I think the answer shifted a bit to no one. But I want to give you a chance to clarify, because I think you and I, not you and I, but there's been some chatting out in the hall in which there's been some clarification, but we need to get this answered on the record.
Well, the clarification is pretty simple. We get calls from everywhere, like I said, from hospitals, community members everywhere, and they ask us if we could help them out with someone. And from time to time we do. Now, when we look at the total number, you look at the total numbers you're looking at, that number is no more than a dozen. The underfunded is our biggest problem. And yes, I've been asked, and I always have the option to refuse. So no one has ever directed me to take a patient that's non-funded.
No one's directed you?
No one. No one of any authority has ever directed me to do that.
Okay, thank you.
Councilor Fraley, I believe you were next.
Yes. Rick, I understand and I agree with part of what has been said as far as your operations are concerned. And I appreciate that you do serve a lot of people. I know you do in Mason County. But I have a problem putting this under Cherokee Nation businesses because that doesn't fit within their scope, their industry scope. So I'm asking you, what would you recommend, or how do you think this should be set up? Apparently they want to make a profit.
When we were initially established, the council at that time basically saw a need, and that need was nursing in the home. Home health and public health nurses actually shared this very building together 30 years ago, and they worked in tandem. So the non-funded patient would go to the public health nurses, and the funded would go to the home health. And so they worked together that way. Over the course of that 30 years, things kind of drifted. We drifted toward only taking funded, and public health nursing became involved in other activities. So what has really crushed us the last few years is so many people presenting themselves, needing assistance, that maybe the reimbursement wouldn't even cover our costs. And so we did what we could for that group of people, and that's put us where we're at today.
Do you consider that this should be a governmental service? As a governmental service, I'm assuming we need to break even, right, Jack?
As a governmental service, I would, because you're looking 5, 10, 15 years down the road, and you're going to see Medicare continually to whittle away at reimbursement. With a balanced budget and the Obama amendments coming at us through the health care plan, those reimbursements will continue to sink. So to try to go into the profit mode, it could create a problem in itself.
Okay. Thank you.
Thank you, Madam Chair. Rick, I'd like to give you an opportunity. You know I work for this body, and what I'd like to ask you is if you could help me understand when you tell this body that no one instructed you to see these patients, and that's not consistent with what I heard in a meeting with you and I and the treasurer. So what I'd like for you to do is help me understand why I'm hearing two different messages.
Well, I guess the meeting that we first had wasn't exactly the most cordial for all of us, and that we're talking two different languages. Doug's coming at it from the tribal perspective, I'm coming at it from the human service perspective. And that particular day, you know, when I said what I said, just like I did to Councilman Fishing Hawk, it appeared from the attorney's point of view that I was saying I was directed, and that's not correct. I made the choice without any over influence or anything. We were asked and we helped some people.
But when we ask you in our meeting, trying to get an understanding of the issues surrounding the financial losses in the last 2 years, you assured us it was centered around the fact of underfunded or non-funded patient treatment.
Very much so.
When we asked why and where did the referrals come from and what influenced that, you told us something different than what you just told this body. And I want to get an understanding as to what miscommunication did I have back then. And I can't speak for Treasurer Horn. She may have interpreted what you said a different way. But the way I interpreted what you said is it was influenced by somebody. And I understand you're not comfortable stating that, but to stand and say no, you know, that was me. Nobody requested this treatment of care, and inability to recoup the Cherokee people's money through these expenditures. I'm just hearing. I heard one thing a month ago, and I think I'm hearing something else now. So just, I mean, all I'm asking is help me understand.
Well, maybe I can give you an insight, just a little bit maybe. And I shared it. I've shared it, and our nurses know it. The industry knows it. From time to time, you try to win over a doctor, or you try to win over a discharge planner, and so to do that, you may assume a non-funded individual to try to get a step and show this individual making referrals that your agency does a good job. And that goes on in every agency. So influence to try to win more referrals, probably so. But influence is a fear for my job or anything else, you know.
Did you not specifically mention to us that it was political references?
I can't recall.
Influences?
Well, there's always that political influence in this organization, no matter who you're talking to.
Okay.
Next is Councilor Thornton.
Yes, Rick. I remember the meeting that we had. I don't remember how long ago it's been, a year or two. But I think I asked then, who are the people that we're funding that can't afford it? And I think that you come back and said it was Cherokees, and said that some of them were not elders, some of them were children,
Yes,
some
sir.
of them didn't have long to live, that's in hospice. And I think that's one reason that I didn't go any further, and I really wanted to fund these Cherokees myself. And, you know, I don't know if I had any influence over you, which I don't think I did, but People, you need to stop and think here what you're doing. You need to start thinking about our people. And these people need to be funded. And it doesn't really make me any difference, you know, if it has to come out of the general fund, if it has to come out of the C&B fund, if it has to come out of the government fund. We need to take care of our Cherokees, and if they're poor and they can't afford this, to have this program, we need to help them, because there's no one out there left to help them. And that's probably the way I feel about it. And making money, sure, we can make money. We've lost millions of dollars right over there at C&I. I'm talking about $18 to $20 million, maybe more. I hadn't got a fact on it here lately, and I imagine it's over there. But I think that was just to keep jobs going and keep our people going over there. But we need to start thinking about our people and our people that need help. And I think this is one way we can help them. And I'm sorry, but I'm going to have to vote for this. Thank you.
Okay, next is Councilor Cherokee Watts.
Thank you, Madam Chair. Okay, so just to make sure that maybe I'm understanding all the issues that are involved. There is a number of issues. First of all, there's tribal consultation that needs to be done with Medicare, Medicaid issues that isn't being done from what I can tell in order to address our involvement in the industry, whether it's for-profit or nonprofit.
Fair enough.
Okay, so I am not clear that the current administration or even the past administration, anyone's been responsive to that. So that is an actionable item out of this, because I hear everyone concerned and they want to move forward, but they're not clear. Then there is the business and health evaluation, because I think there's a business opportunity that C&B could take a portion of the work you do, serve everyone, and generate dollars and create jobs. But there's also something that health needs to evaluate in conjunction with your group, because you have a board that oversees you, correct?
Correct.
We affirm those nominees when they come in front of us. And so that we need to go back to the legislation only after a plan's been developed so that we can really evaluate it. That's where I'm struggling. There's not a clear plan. We need to know where your financials are at today. We need to, I think it is wrong on our part or anyone involved to ask you to come back every 3 months or 6 months and kind of beg for money. That does not set you, your agency, or the employees up for success to think about. So if there's not a long-range plan about what that looks like in order to fund the unmet needs of some of the people that can't help themselves, the people we're supposed to be helping as a government. So we need to know what that is. We need to know what that is in conjunction. When I've talked to you in the past, I've heard that there's communication issues with Cherokee Nation Health Services as well as Claremore Indian Hospital.
That's correct.
About the use of your facility, your services, whether it's their ability to pay or not, even referral. So I guess I'm saying all that to make sure I'm hearing everything and the complicated issues involved. I would rather table this for a month to see if we can come to some kind of consensus on agreement and get a path forward, moving forward. Because if I were to have to vote on it today, I could not support it because I don't have enough facts in front of me to make a rational decision. That's the way I view it. Because again, the councilwoman from Cherokee County referred to it that this would be like the third time we've had to set funding out, and it's still not clear to me where we're going with this, the lack of direction. I don't know that I think we have to understand how we got here in order to move forward.
That's a very good point.
And none of that is here today. That information's not with us today to make a decision. I'm going to make a motion to table for 1 month.
Do we have a second?
I'll second it.
Okay, the motion has been made and seconded to table for 1 month. All in favor?
Aye.
All opposed?
Aye.
Roll call.
Huskin Jr.,
No.
Tana Gloria Jordan,
No.
Lee Keener,
Yes.
Dick Lay,
Nope.
Curtis Snell,
No.
David Thornton,
No.
David Walkingstick,
No.
Kara Cowan Watts,
Yes.
Bill England,
Yes.
Jack Baker,
Yes.
Joe Byrd,
No.
Julia Coates,
Yes.
Jody Fishinghawk,
No.
Meredith Fraley,
Yes.
Janelle Fulbright,
Yes.
Don Garvin,
Yes.
Frankie Hargis. We have 8 yes and 9 no.
Call for the question.
Okay. Question has been called. Vote. Let's explain the question.
The question is whether we approve giving him $262,000 to cover his losses.
Okay.
And I guess a vote of yes is we give him the money. We don't know where the money's coming from, but we would give it to him. And a vote of no is, no, he doesn't get the money.
Okay, we'll call for the question.
Roll call.
Roll call vote
This is on to approve number 2.
to approve number 2.
Curtis Snell,
No.
David Thornton,
Yes.
David Walkingstick,
No.
Kara Cowan Watts,
No.
Bill England,
No.
Jack Baker,
No.
Joe Byrd,
No.
Julia Coates,
No.
Jody Fishinghawk,
No.
Meredith Fraley,
Yes.
Janelle Fulbright,
Yes.
Don Garvin,
Yes.
Frankie Hargis,
No.
Chuck Hoskin Jr.,
No.
Tana Gloria Jordan,
No.
Lee Keener,
Yes.
Dick Lay.
Nope.
We have 5 yes and 12 no.
Okay. Now let's have it.
Madam Chair,
Yes.
just one minute. I want to thank you again for your attention to the matter, and I'm looking forward to the council and administration really getting into the needs of Cherokee people and home services. On one other matter, I would like to offer my services to Councilman Jordan regarding her questions around CHP and Cherokee Health Partners. I believe I can help you out with all that information. Thank you very much.
Rick,
Yes, sir.
how long have we been running this home health program?
If I make it till September, it'll be 17 years.
Yeah. And during all that time, it seems like we have not done a feasibility study to determine how our revenue is going to be,
Correct.
Now,
If you look at the tribal numbers, Councilman Byrd, and where our tribal members are scattered, it's a miracle we're even still standing. 30%.
so we need some direction, and we need to get some goals
We
and
need a
objectives to
comprehensive.
you to make sure. It's like being out on the ball field not knowing your place.
Good analogy.
Very good analogy.
I'm on the
Because I've been
field.
on both sides.
Been hit quite a bit.
But with that, I'd like to thank our treasurer and Doug for information you provide us. Very helpful. We want to work with you, Rick.
Appreciate it. Thanks.
Thank you, Madam
Councilman
Chairman.
Rice
Rick, yeah, this is no reflection on you, but if 1981 was when this model was brought to life, then it's 31 years, maybe it's time to look at doing something else, just like Joe said. I mean, we need to give you all direction, the administration needs to, and let's gather up and figure something out that where y'all can go forward here.
That's kind of been the last 16 years worth of history. Good statement.
Thank you.
Rick, I want to kind of elaborate on what Councilman Byrd said, and I know exactly what you've been doing, because when you got out there and you didn't know the place, you shot, just like Joe did. Whether you come up 2 points or not, I don't know.
Fair enough.
Pretty good analogy.
Really?
You're hitting them.
Rick, on CHD,
Yes, ma'am.
would you mind getting with Doug Evans? And I believe we're going to want to do the same type of analysis.
I think Doug's growing on me.
If you would, I would appreciate it.
Be happy to.
And again, I echo Dick Lay's thoughts. This is, the decision today to turn this down is not a personal reflection on you. It appears there has been periods of time where you were not getting the direction that from this body that maybe needed to happen, and we're gonna, hopefully we'll try to fix that.
Appreciate that.
Counselor Snell.
I'd just like to make a comment that we really do need to help our Cherokee people that can't help themselves. And I was thinking we need to help you learn how to do this, or all the bodies learn how to make this progress forward.
Appreciate it. Thank you, Madam Chair.
I want to say one last comment. We appreciate you coming here today. You have a tough job to do. And what really put me to thinking was Counselor Thornton saying where he had met with you previously, seeing that some of these people were children, people on hospice who had, we were their last resort. And I know we need to think of a way to do it better. I don't know if we're really in the business here to make money, but at least we want to break even, because most home healths do show a profit. So maybe we can all work together here, but we do appreciate what you have done, and maybe we can go forward.
Well, I'd just like to say we have a few hundred nurses and nurse aides that get up every morning, 7 days a week, and go take care of folks. So, compliment goes to them, not me.
Okay, thank you.
Madam Chair.
I think this wraps it up, and we need a call for a
To adjourn.
Okay, all in favor?
Aye.
Our next meeting is March the 12th, 1 p.m. Thank you, everybody, for a long and continuous meeting. I think we accomplished something.
We did.